like to bring up John Goodman, president of Goodman Institute for Public Policy and Research. I've heard so many great things about you and your work over the years from a lot of very close friends of mine, and so very, very excited to have you here, and thank you so much for traveling up here to be a part of our task force.
Glad to be here. I'd like to cover 3 issues this morning, if we have time. Surprise medical bills, telemedicine, and the opportunity to take advantage of short-term insurance created by new Trump administration regulations. But what I'd like to do first is just give you a quick overview of why we're having all of these problems. The reason I have this cell phone with me is not because I expect an emergency call, but to make an important point. If something happens to my cell phone in Dallas, Texas, there are a dozen places I can step into without an appointment and get low-cost, high-quality repairs. There are even places that will send someone to my home and repair my iPhone in my condo. But if something happens to me, the person, the average wait to see a doctor in the United States is 3 weeks. And in Boston, where we were told they had universal coverage even before there was Obamacare, the wait is 3.5 months. And 1 out of 10 people who enter an emergency room in the United States leave without ever seeing a doctor because they get tired of waiting. In some California hospitals, it's 1 in 5, which is what it is up in Canada. And so the question is, why is the market so kind to my cell phone and so mean to me and you? And I think the reason is that this cell phone is produced and sold and repaired in a real market with real prices where entrepreneurs know they can make millions of dollars by meeting our needs. But over in healthcare, we have so suppressed the market year after year, decade after decade, that none of us ever sees a real price for anything. No patient, no doctor, no employer, and no employee. So we like to think that our system's really different from the Canadian system. And I may have even contributed to that perception. But the truth of the matter is we're 80% just like Canada. In both countries, the primary way that we as patients pay for health care is not with money, it's with time. In Canada, you see the doctor, it's free. In the United States, you see the doctor, it's almost free. Every time we spend $1 at the doctor's office, only 10 cents is coming out of our pocket. The other 90 cents is paid for by the government or insurance company or an employer. And we bought into the same idea the Canadians have bought into and that people all over Europe have bought into, and that is that no one should ever have to choose between health care and other uses of money. And what we forget is that when you suppress the price system, when you suppress markets, you elevate the importance of non-market barriers to care, and in the process create all kinds of perverse incentives. And what are non-market barriers to care? They are, how long does it take you on the phone to make an appointment with a doctor? How long do you have to wait? How many weeks, months to see that doctor? How long does it take you to get from your home or office to the doctor's office and back again? Once you're there, how long do you wait? Those are all non-market barriers to care. And there's a lot of evidence that even for low-income people, these non-market barriers are a greater deterrent to getting health care than the price that the doctor actually charges. So I think telemedicine is a real answer to that problem. For perverse incentives, that's, in my opinion, the reason why we have the whole problem of surprise medical bills. So let me just cover that for just a second. We don't have surprise bills in other insurance areas. So if you have homeowners insurance or auto liability insurance, other kinds of insurance, we don't have surprise bills. So why do we have them in healthcare? I believe the reason we have them is because insurance companies today face very perverse incentives. So we've told the insurance companies that you have to charge the same premium to everybody regardless of health condition. And you don't have to be in the business to think about that very long to realize that you're probably going to make a profit on healthy people and losses on sick people. So what the insurance companies are doing is trying to attract the healthy and avoid the sick. And you see this in spades in the Obamacare individual market where we have a real race to the bottom. Worse than what we see in other insurance markets because it's become so competitive. In Dallas, where I live, there's not a single policy in the whole individual market. You cannot buy insurance on your own in Dallas that will get you into UT Southwestern, which is probably the best medical research facility in the whole world. In Texas, generally, you can't get into MD Anderson with an Obamacare policy. So what's happening is a real race to the bottom. Centene, the name some of you may have heard, is a Medicaid contractor. That's what they used to do. And now they are responsible for 1/5 of all the Obamacare policies sold in the country. And what are they selling? They're selling Medicaid with a high deductible. And MD Anderson is saying, no thanks, we don't want you. And UT Southwestern is saying the same thing. So what the surprise medical bill is just another aspect of this whole problem. What happens is you go in the hospital and the insurance company told you it was Blue Cross. Blue Cross told you HCA is in the network, and HCA told you that Blue Cross is we're part of Blue Cross's network. And then you get a surprise bill, a doctor or a service that you're told is out of network. And in a normal insurance market, people would be upset. They would go to some insurer, and insurers would have an incentive not to let this happen again. If you think about the kind of advertisements you see on TV for casualty insurance, so the Aflac Duck, Allstate, every TV ad you see for insurance for casualty insurance stresses how good they're going to be to you once the bad thing happens, right? For the Aflac Duck, it's all bad stuff happening. For Allstate, the town's been wiped out by a tornado, and you're going to be in good hands. The message is always the same. We're going to be there for you. But what happens over in health insurance? You're never going to see an ad saying, if you have cancer, come to us. If you have heart disease, we're the insurer for you. So we have created in the health insurance area the exact opposite of the incentives that we have for every other kind of insurance. So when the patient comes in the hospital and gets a surprise bill, the insurance company doesn't pay it. We stick it to the patient. And why does the insurance company do that? Because insurance companies don't want people who go to the hospital a lot. By not paying those bills, they can make their premiums lower for all the healthy people who aren't going in the hospital. And in my opinion, that's the reason we have this problem. Now, the best solution is what I call the FTC solution. And I just think it's fraudulent for an insurance company to say that hospital is in our network, and you go to the hospital and find out that not everything was in network. And similarly, for the hospital to make a similar claim. So my FTC solution is we won't allow this to happen. So if Blue Cross wants to say the HCA hospital is in network, everything better be covered there. And if the hospital wants to claim that it's in Blue Cross's network, everything, again, ought to be covered. And if they can't claim the network exists. So if we had that kind of rule, this problem would be solved overnight, okay? Because Blue Cross wants to let you know that the hospital's in network. When people buy insurance, they look at two things, deductibles and co-payments. But if Blue Cross said to you, if you go over to that hospital, these deductibles and co-payments may not apply to you. We can't tell you in advance whether these are going to apply or not apply. That would greatly reduce the demand for Blue Cross policies. So that's the ideal solution. Now, since the FTC isn't enforcing this rule, let's go to the second best. And there are three ways that people are proposing to deal with this. A way that favors insurance companies, a way that favors doctors, and one that I think is pretty much down the middle. The Senate bill that is the Alexander bill that passed out of Senate Labor earlier this year says all of these approaches protect the patient from surprise bills. But there's no free lunch, and so if the patient's not going to pay for it, somebody has to pay for it. And what the Senate bill says is, okay, doctors, the insurance company only has to pay you the median rate that it pays for in-network doctors. That's great for insurance companies. The Congressional Budget Office says that's like transferring 15 to 20% of doctor incomes over to the insurance companies. So they like it. And that's pretty much what California, for example, has done. Now, the other approach is one that favors doctors, and that's pretty much what New York has done. And New York says they have forced arbitration. So if there's an out-of-pocket surprise bill, the doctor and the insurance company have to negotiate a settlement. If they can't agree, it goes before an arbitrator. But the arbitrator is instructed to use as a benchmark 80% of whatever doctors charge. So that's really good for doctors. The middle-of-the-road approach is Senator Cassidy's bill. Cassidy is a senator from Louisiana, probably knows more about health care than anybody else in the Senate, by the way. And what it says is, for a surprise bill, patient is held harmless, and we're going to go to arbitration, or either side can force arbitration. But we're going to benchmark not what doctors charge, but what they're actually paid. So it's kind of the middle of the road. And I don't know if you all probably know more about arbitration than I do, but most arbitrators are former judges. So what you're likely to get from a former judge is what you probably would have gotten had you gone to court and spent a lot more money. And furthermore, arbitration takes time and money. So once the insurance companies and the doctors figure out what's going on, they don't do it. They negotiate a settlement and avoid those costs. So I would recommend the Senator Cassidy approach. Arbitration could be forced by either side, and the benchmark is the charges that the fees that doctors are ordinarily paid, but the judge is free to consider arguments from both sides. And maybe I should stop right there, and let's see if we have any discussion or questions about surprise medical bills before I go on to these other two areas.
Anyone on the task force? Yes, sir. Go ahead, Doctor.
Question. Last session, we had a presentation on the administrative costs of medicine and how the administrative costs of medicine are crippling the system. This would potentially require an increase in administrative costs on both sides, not only the physician side, but also the insurance side, if we had to engage in forced arbitration. How does a program potentially look at those administrative costs and keep them from ballooning?
Well, if every single bill went before an arbitration court, that would be expensive. But that's not what happens. In the first place, you can group claims. So let's say Jackson Health, which is here in Atlanta, and one of the things they do is they supply medical personnel to hospitals. So they might take all of their cases and maybe against Blue Cross and go into arbitration as a group of claims. The second thing, though, is that once you have a few of these arbitration results, they quit doing it because, as you say, administrative costs are expensive. They eat up capital, and no one wants to do that. So if we know kind of what's going to happen, then the two sides come together and agree on something. In states that have forced arbitration, there aren't that many arbitrations.
So just to unpeel that a little bit, so you're saying that the arbitration would eventually set the market,
Yes.
or the market expectations if further action was taken through arbitration?
Yes.
Understand. That's what the projection is. Jesse? You're going to need to move that closer.
Mr. Goodman, could you get into the differences in some of the arbitration schemes around the country, and particularly the Texas arbitration?
You know, I don't know what
Process.
Texas does, but what Senator Cassidy is proposing
Or the baseball style.
is a baseball-style arbitration where each side makes a claim and the judge has to decide between them. And that seems to work pretty well.
And an interesting play on that is, I don't know the exact percentage, but it's 90+ % of potential arbitration scenarios end up not going to arbitration because the sides agree, advancing that baseball model.
Well, it's like in court cases generally. I guess you all know that 90% of all court cases never go before a judge and jury because people are risk averse and they make some reasonable judgment about what's going to happen. The same principle is true here.
Mm-hmm. Go ahead, Clark.
You were talking about the issue with the hospital and the patients. So in all the major markets in the United States, we're ending up with typically 3 or 4 hospital systems that are ending up dominant in those markets. And they buy up the medical practices, they buy up the labs, they buy up the diagnostic centers. And so in our market, we have 4 that have done that. So they are all about buying a practice and raising the cost to the patient or the ultimate payer for those. Wouldn't we have better market incentives if the 4 hospital systems, let's say in this market, or 3 in another, were the ones that actually provided the coverage to the patient or the employer for the patients, where they would have a direct market incentive to control costs because they were both providing the insurance and the care.
Well, there are two issues here. One, Medicare payment rates encourage hospitals to buy up doctors in a perverse way. Because a doctor can provide the same service for a hospital and they can bill for 2 or 3 times as much as he could on his own. And Seema Verma, who runs Medicare, Medicaid, HHS, they all understand this is a problem. They're trying actually unilaterally to pay the same rate, and they may be challenged in court for doing this. The Trump administration has been very, very aggressive on changing a lot of bad regulations. So anyway, we don't want to encourage concentration if it's not a natural market result, because we know that concentration leads to higher prices, and turns out it doesn't lead to higher quality either. So the other issue is you might ask, why does Jackson Health need to exist, or companies like that? The answer is that if you're a hospital and you need an anesthesiologist, your need for them goes up and down. You don't know, how many times you're going to need one in a given week. And so if you had to employ all the anesthesiologists so that you could meet the peak demand, then when you're down here, you've got a lot of people standing around doing nothing. So what a company like Jackson Health does is it helps put supply and demand together. So the hospital gets the anesthesiologist when they need it for a reasonable price, and they don't have to keep everybody on staff. So those are the two considerations I would just give to you.
Anyone else has a question? Go ahead and continue.
Okay, telemedicine. There's a huge opportunity here to lower costs, raise quality, and increase access to care. Now, Senator Cassidy the other day told me his daughter has a rash on her arm. So he holds the phone up to the rash. The dermatologist is on the other end. The dermatologist examines the rash and prescribes a drug. Now, with CVS all-night pharmacy delivering drugs, in principle, the Cassidys never have to leave their home. And there's so much in medicine that could be done this way that it's just almost mind-boggling. Most people think that half the people in emergency rooms don't need to be there. So half the people could be treated elsewhere, a lot of them in their own home. The estimate is that maybe 30% of all doctors' visits could be done in the patient's own home. We've got ways, with the phone, with an app or two, you can diagnose the child's earache, a sore throat. A friend of mine has this Fitbit device that monitors his heart rate all the time. You don't have to go to the hospital or a doctor to test your heart rate. It's constantly being monitored. It also monitors his sleep. So the potential here is just great. And why are we not using it? Why does Medicare pay doctors the same way it paid them before there was an internet, before there was a cell phone? We haven't changed a bit. And the main reason is because Congress passed a law saying that Medicare can't pay doctors to diagnose patients with a telephone. So it's very limited under Medicare. The patient has to be in a rural area, and he can't be in his own home. And why do we have that rule? I'm sorry to say it's because of doctors. Doctors who feared competition from the telephone. Now, Seema Verma has made some baby steps in the right direction. She said just unilaterally, okay, we're going to let the doctor talk to the patient for the purpose of seeing whether an in-person visit is needed. Okay, and she's also said the patient can send data, which means pictures and things, to the doctor. She'll probably be sued by somebody. But we shouldn't have to be doing this. There should be no restrictions on telemedicine. Now, as we've said several times, I live in Texas, and that's also the home of Teladoc. In fact, Dallas is the home of Teladoc. Teladoc has 11 million people who have the potential to talk to a doctor on a cell phone. And the Texas Medical Association tried to run them out of business. And they went to court, and it was a court case that lasted several years, and eventually Teladoc won. But let me just give you one example of why the doctors lost. So they're in court, and they asked the doctor, well, sir, if you're practicing medicine with a group of doctors, and you go on vacation, and you ask the doctor down the hall to cover your patients, and the patients call in, and you've never seen the patient, you don't have medical records, but they need a prescription refilled, and you refill it over the phone, is that okay? And the doctor said, yeah, that's perfectly fine. Well, of course, that's no different than what Teladoc is doing, except the Teladoc doctor has a medical record, and it's electronic, and he knows the history, so he knows more than the doctor down the hall. So the court ruled, and I think public opinion was on the side of Teladoc on this issue. I would just encourage you, I know you have some restrictions here in Georgia, I would encourage you to get rid of all of them. There's no reason for us to be paying doctors the way we did before there was an internet and ignoring all the potential from the technologies sitting right in front of us. And maybe I'll pause there before I go to the third issue to see if anybody has a comment.
Anyone have any questions?
I see we got a couple of doctors around the table.
Well, yeah, and I was going to ask. I was asked the doc's opinions, kind of as to engage, because I think look, this on the surface looks like it's two-dimensional, but it's a three-dimensional issue, right? You've got adoption and adaption and users and patients and ages, and the comfort with technology. All of that is complex, but I'd love to get the doctor's opinion on where they're.
Six. We're outnumbered here.
No, I would have to say that Georgia's not like Texas, and that Georgia has been friendly to telemedicine. In fact, we passed 2 bills on telemedicine this last session. So I think, and maybe Dr. Esper can speak to this, but I think Georgia doctors have welcomed telemedicine and have not fought telemedicine the way it's happened in Texas. So unless I'm missing something.
Okay.
And I would say that from the perspective of Senate Bill 118 in particular, which establishes payment parity for telemedicine, it was a great step forward for Georgia. From a value-based perspective, many of the organizations that Clark alluded to earlier are desirous of value-based care and meeting the patient where they are. I think that things that could even go further is to establish, for instance, the lack of a site restriction on where the patient can access telemedicine from and what the insurance company will pay for. For instance, it would be nice for me to be able to do a neurology follow-up in the patient's home and actually get paid, for doing that as opposed to making a patient go to a clinic. So there are further steps that can be taken. I would actually say that it's a complex problem, especially when you're getting into transplant patients and very high acuity and highly complex patients. So we need to be thoughtful of all of those considerations in and how we deploy telemedicine.
Yeah, and the other thing I would point out is that the challenge to the very, very front end of healthcare delivery is the broadband problem across the state in rural areas. So it's an infrastructure issue. I don't think any of the docs I go to a lot of rural areas, believe it or not, and that is the challenge. So that's completely outside of medicine. Fix our broadband problem, and people will take it up overnight.
What I have suggested to Senator Cassidy and his colleagues is that we just need a one-line bill for Medicare. And all it needs to say is Medicare is free to pay for telemedicine. And then Seema Verma and her colleagues can decide, what price they want to put on it and what services they want to pay for. But I don't see why this needs to be a legislative issue. I don't see why the market can't solve these problems.
Go ahead, Doc.
Number 11. Thank you very much. I appreciate what you're saying. And so I do primary care, internal medicine in a larger group. And, you know, if you don't embrace, you know, the quality and innovation today, I mean, I think that's doing harm to our patients. And, I mean, I think that you have to do that. And I agree with you. More competition increases the quality of care that you do. You know, if you don't embrace the technology, you're going to sort of get left behind. I have not gotten that feeling in the state of Georgia, but you know, our Medical Association of Georgia, your comparable Texas Medical Association, certainly has not been on that. They, from my perspective, has encouraged that. I'm not here defending one versus the other than to say I agree with you from a less regulation, more transparency, knowing what you're paying for, and allowing that to happen is good for the patient.
Good. I don't know what the restrictions are on Medicaid, I'm sorry to say. But I do know that in New York they have a pilot program up in the Albany area, and this is baby steps in the right direction. So in these three counties, the Medicaid patient uses a cell phone for triage. So if the patient has a problem, they call in. A doctor advises them on whether they need to go to the emergency room or whether they can wait a day or two or do something else. That's a baby step. But I would think in Medicaid itself, there should be opportunities to save a lot of money, greatly increase access to care. I know is Grady your safety net hospital here? In Dallas, it's Parkland. And in Dallas, Medicaid patients have a real hard time finding a doctor who will see them, so they go to community health centers or they go to Parkland Hospital. The wait at Parkland can be 4 or 5 or 6 hours, depending on the time of day and day of the week. That's not very good access to care. So I think Medicaid, certainly where I live and probably here too, could be greatly reformed if we took advantage of the technologies sitting in front of us.
One of the questions I'd ask the docs here, just to kind of weigh in on, is there any sense from being a doctor of an increased liability level based on engaging with a telehealth relationship with a patient, you know, whether it be a misdiagnosis? I mean, the terms are above my pay grade here because I'm not a doc, but is there this maybe increased sense of liability, or is the marketplace, you know, covered that or in the process of?
I think that's one of the key questions and the reasons that people are hesitant. I think it's fair to say that the context of when you would be able to comfortably deliver telemedicine is what is going to drive a lot of the nuance, as you said, as people think about what is appropriate and not appropriate. And so there may be some blanket scenarios where people say, well, that you know, you're going to need to come in for anything. And I know at Georgia Tech, we got the new USG benefits for next year, and they say we have a telemedicine benefit that it covers like viral this or a couple of different things we can call and use, and they've scoped it. So I think that the question of liability is very high in people's minds, as it is with any phone call. When you're on call over the weekend and you get a call from a patient you don't know, you're listening really carefully, and if you're not sure, you are going to say you probably need to go in and get that checked. And I think it would be the same kind of thing where telemedicine would have kind of boundaries that become sort of developed by the practice around what is appropriate.
I had a rural-urban question for you. In Georgia, we have 159 counties, and about 110 have virtually no access to medical care. So what about the role of physician assistants and nurse practitioners to deal with rural areas of states where doctors aren't going to set up practices because it's not lucrative for them?
Well, here again, we have regulations that impede the solution to these kinds of problems. So we have more than 2,000 walk-in clinics around the country. In CVS Pharmacy, they're called Minute Clinics. They're run by nurses. The evidence says that these nurses, following computerized protocols, follow best practices as well or better as traditional primary care physicians for those kinds of conditions that they're qualified to treat. So it's high quality, it's low cost. As the name Minute Clinic suggests, they know your time is valuable as well as your money. But at least in my state, Texas has some of the worst regulations in the country. And so they tell them in a clinic, well, the doctor has to come by and visit and talk to the nurses so many times a week or so many times a month. And this is very difficult in rural Texas. So we don't have minute clinics in rural Texas. So one problem is that kind of regulation. The other problem is we're not allowing market prices to determine what happens. So at a minute clinic in Dallas, an earache or sore throat would probably cost $75 or so. The amount that Medicaid will pay is half that. So the minute clinic says no thanks. So the sore throat goes down to Parkland and waits 4 or 5 hours for something that could have been handled for far less money and in much less time. So I think minute clinics could be both in the urban area and in the rural area, delivering a lot more care to a lot more people if we just let market prices prevail and get regulations out of the way.
I have a kind of a follow-up question for you. Well, actually, two of them. One, I've been following those retail clinics since the 90s, and recently Walmart has come out with a model that's turnkey, wireless. The problem has been handling complex chronic disease, which is really a challenge. It's not just sore throats and earaches and athletic physicals. So the other part of that is, what's the potential for fraud in telemedicine? I've not heard anybody talk about that. And so part of the reason we have some of these regulations is to protect payers from fraudulent billing. So do you have any experience with that, or can you comment on that?
Well, I have a thought about it, and that is that the private sector is so much better than government in dealing with fraud. The estimates are that 10% of all Medicare dollars go to fraud. And occasionally 60 Minutes will do some special about how down in Florida doctors are stealing millions of dollars. But do you know, on your credit card, the fraud rate is less than 1%? And think how many times you hand a credit card to somebody and they go off somewhere and you don't know what they've done with it. So the opportunities for fraud, you'd think they're great. It's 1%. So there are private sector solutions to the fraud problem that seem to work well. And we ought to think about doing it in medicine.
What about the complex people?
Well, Minute Clinic isn't set up very well for chronic problems. I don't know whether Walmart's going to be good at it or not. The whole insurance industry is not good on chronic problems because, again, we're giving them incentives to run away from patients with problems instead of paying them to handle problems. In the kind of reform I think we need is for Congress to give to Georgia, let's take the individual market. Congress needs to say to Georgia, you can do almost anything you want to in the individual market so long as things get better for people who are sick. So pre-existing conditions, they have to get better. You have to reverse the race to the bottom. As long as you're doing that, you should have the freedom to do whatever you want to do. So what would that freedom entail? It would entail medical records traveling with patients. It would entail centers of excellence like Cancer Treatment Centers of America coming into Georgia and saying, okay, we want the cancer patients. If you don't have cancer, we don't want you. You can't do that under Obamacare. So asking for medical records, asking medical questions, specializing in diabetes or cancer or heart disease, all of this could be happening were it not for unwise bureaucratic barriers.
Go ahead.
Just, Lieutenant Governor, to answer the question about, what can you do? Is there a liability? The examination, et cetera. In most health systems, especially the doctors, look at telemedicine as a potential tool to help them deliver value to the patient. So, for instance, with Winship Cancer Institute and medical genetics counseling, that's a very important aspect of care, and that would need to be that does not need to be necessarily delivered in person, but there are certain aspects of care that do need to be delivered in person. And so what health systems that are trying to, and doctors and practices that are trying to deliver value to their patients, that they would need to compete on, trying to make sure that the patient has the ability to access the right care, how do you use the different tools without increasing your liability and being able to deliver that value to the patient to give them the care in the right venue? I think that is an important consideration. And to the degree that we can limit barriers to certain venues of care, that will be a huge boon for the doctors, the nurse practitioners, and the health systems that are trying to deliver value to the patient.
Yeah, I think in my own personal scenario in our home, we were not telehealth consumers until we became cash payers. Before we were on the state health benefit plan. And so when we were incentivized, and all of a sudden now it's just part of our normal healthcare routine with our 3 kids and whatnot. I wonder, what the play out would be in a private sector model if all of a sudden the demand for telehealth from a consumer side, from the patient side, became 2x or 3x, right, through an incentive model. Then I think the market conditions and the liability, all of that would be accelerated to kind of get to solution stage. And also the payment parity and all of that would continue to get stronger and stronger and more in line.
Yeah, I think that we would concur with that, and what you would rapidly start to see is that the models of care would accommodate this increase in a way that's beneficial to the patients. I think that's at least where we expect it to head.
Right.
Just one more comment on this. It's probably unfair to compare medicine to law or accounting or some of the other professions, but in all the other professions, this has been easy. I talk to my lawyer by phone sometimes by email, sometimes in person. Same thing with the accountant. It just is. It's just not been a problem. Again, I admit it may not be fair to compare medicine to these other professions, but elsewhere these problems seem to have been dealt with.
Just one comment about
Okay.
that. I'm
Sure.
an orthopedic surgeon, and in my practice, there's maybe a few things that could be delivered electronically, but the physical exam is a huge part of certain specialties, and I think what Dr. Esper said is absolutely right. It's complex, and the goal would be to get the patient to the right method of delivery of care and in the right setting, and that's what we're trying to get to. But I don't think we're ever going to get to a point where it's going to be like law or accounting, because the physical exam doesn't come into play in those specialties.
Well, what I've been told, what I've actually written about, is that after the knee replacement or the hip replacement, the patient then goes to a recuperation center or maybe even in his own home. And then devices exist so that the patient can be monitored, and he doesn't have to get in the car and go to the doctor's office as often as would otherwise be the case. And this is good for the patient and probably good for the patient's health.
Well, and those solutions are currently being deployed.
Yeah.
So, for instance, in the post-operative follow-up situation, is the patient moving their knee appropriately, et cetera? But then the issue comes, well, what happens when the leg swells? And that requires knowledgeable physicians and knowledgeable practitioners to be able to deliver them to the right venue of care. And then it would be remiss not to say that we do need to keep an eye on tort reform. And understanding, what liabilities are potentially out there and how we can make sure that that people are incentivized, that the health systems and doctors and nurse practitioners, et cetera, are incentivized to use it without fearing the risk of legal repercussion for inappropriate lawsuit.
Yeah, and I know you've got one more point to make, and you got 10 minutes, so I just want to soak this up, kind of combining both of those conversations. So I've had 2 shoulder surgeries over the years, unfortunately, and the rehab part of it, so Dr. Kirkpatrick, you're spot on, where there's certain spots where the ortho has to be with you. There was some lead-ups. My son just had a shoulder surgery. There were lead-ups where there was conversations, via telehealth, just identifying what range of motion is being restricted. And then also in the rehab process, at $186 a rehab session when my son gets in the car and I'm like, how did today go? And he's like, went okay, right? And I just know I paid $186 for a rehab session. I get a little animated about that. I want him to get in the car and say it went incredibly well. And so there's obviously, I think, opportunities for technology to integrate with ongoing, care and follow through. So great point. All right, last point. Dr. Burke, go ahead.
Just wanted to say, if we had a cure for the way teenagers reply to mom and dad, we wouldn't be here.
And if any of my kids are watching, see what he said. Go ahead.
All right, let's talk about short-term insurance. It's been around forever, and what it traditionally has been up to a year, typically. It's a student going from school to work or people changing jobs. It's literally short-term coverage in between getting covered by a more conventional kind of insurance. So the Obama administration comes along and restricts the ability of short-term insurance to 2 months. Okay, so you can only have 2 months of insurance, and that's it. Trump comes along, and I'm not sure Donald Trump knows this, but the Trump administration changed the rule, and now it can be 3 years. And so you can have 3 years of coverage, and furthermore, you can have a gap, what I call health status insurance, a second policy that covers you in moving from the first 3-year period to a second 3-year period. Now, the reason you need that is because this kind of insurance is not regulated by Obamacare. Okay, so they can ask health questions. They can charge more if you have a pre-existing condition. So if you had this insurance for 3 years and then you applied for another 3 years and your health had deteriorated, they could charge you a higher premium. So what this gap insurance does is it protects you against that higher premium. So by combining these two types of insurance, the short-term insurance plus this gap insurance, you could indefinitely, literally recreate the individual market that you had before there was Obamacare, if you wanted to. I don't see anybody talking about this except me and a few other people. But what I have suggested in Texas is up to 12 months, let the insurance companies do what they've always done, let them do whatever they want to do. But if they want to go beyond 12 months, let's put some restrictions on it. Let's say if you want to sell insurance that lasts 3 years, you have to sell the second gap type insurance to get you, onto the next 3 years and definitely into the future. And also, some of my board members are actually proposing to the insurance commissioner in Texas that we have something that looks like a traditional Blue Cross plan. And that would be, and the state would set the benefits and would also set the premium. And then the insurers would compete mainly on service, including the telemedical services, by the way. And this would be insurance that costs a lot less than Obamacare, and it wouldn't have all the essential benefits of Obamacare. And I think it's something that you all ought to consider because it's you're greatly constrained on what you can do in the individual market, and even with your waiver requests, you're still constrained. But over in the short-term market, you're not constrained at all. Now, this health reimbursement arrangement where the administration now says employers can put money into a health reimbursement arrangement account and you can buy individual insurance. You can't buy short-term insurance. But there's a second kind of account where they can put $1,800 into it, and that can be used for short-term insurance. So there's a way employers can help employees get into this market. Right now, that's the one market where you have, as far as I can tell, great freedom to design your own insurance industry.
I think one of the interesting parts, or I think one of the big benefits to the past couple of months, the 1115 and 1332 waiver, and kind of the way the waivers have been written here, and Ryan, feel free to speak to this, is that they have not pigeonholed us into any sort of individual silos. It's allowed us to be innovative and creative ongoing. I think the ultimate answers around healthcare are not going to be figured out in partisan corners. They're going to be found out in innovation hubs, incubators, free market kind of exercise, insurance providers, everybody kind of being at the table saying, what is modern medicine, what does delivery of modern medicine look like? Government's going to do a terrible job at that. I'll just predict the future. And so, if you want to speak to, have you heard anything here that maybe limits us, or where you think Georgia is positioning ourselves on these waiver process, to kind of be in a good spot?
I haven't heard anything that's necessarily limiting us, and after having gone through the past 6 months and taking the deepest dive into the individual market here that I think anybody has ever taken in the state's history and its participation with Obamacare, there are a lot of challenges that obviously exist within the state's constraints currently, and by waiving a lot of those through our waiver application that's online now, we aren't, like you said, constraining ourselves to any pathway, I don't want to use pathway, but any path to reform the individual market. I mean, you mentioned the HRA arrangement. One of the things that we're proposing to do that doesn't interface with the waiver application itself, but within the constraints of the ACA and whatnot, is by allowing HRA contributions to be combined with a state subsidy structure that's part of the federal subsidies that the state will not have control over. We're going to breathe a whole lot of life into the HRA rule and allow for that, and for small employers and employees of small businesses to be able to take advantage of two funding streams as a result of existing cash flows and some IRS rules and whatnot. And I think that's huge, and a conversation that's being missed kind of over the past couple days and whatnot, and in the future, that we are going to be able to breathe a lot of life into the HRA rule, and that's a function not of the waiver itself, but of the overall market that we've created as a result of capturing those federal subsidies in the form of state dollars now.
I don't know how much detail is in your waiver application on how the reinsurance is going to work, but I think it should be as much of a market as you can make it. And under the old risk pool, if you went into a risk pool, you got something that looked like a Blue Cross plan, but there was no competition. And if people are going to risk pool or they need risk insurance, they have a problem. Probably it's a chronic problem. And we need a market, in my opinion, for chronic care, and we don't have one. So this gets back to some earlier questions. If you want a market for cancer care, diabetic care, heart care, then the companies need to be able to bid, and they need to be able to get compensated for their costs. So I would encourage a bidding process where you invite Cancer Treatment Centers of America and other centers of excellence into your market to bid on the, and of course the patient would have to agree, but create a market for chronic care. Right now everybody's running away from chronic care. We need them to compete to solve problems.
One of the biggest issues that, I don't know if we talk about it enough, but it truly is that an overwhelming majority of people in this country don't care about health care until it hurts so bad that they can't stand it or they can't afford to kind of treat themselves. And so it becomes an issue. And so we've got to continue to look for ways to have buy-in. I want to applaud, kind of yesterday's announcement is really trying to look for ways to have an involvement in your own personal health, whether it be $7 or $70 or $700, whatever that scale looks like. Because if you don't have buy-in and you don't care until it hurts, then you'll pay anything in the world, or you'll let somebody else pay all that they can pay to deliver that health care, and that's not productive to anybody within that healthcare ecosystem.
The the House Republican Study Committee came out with a series of recommendations the other day, and one of them is to divorce the health savings account from the deductible, which is something I've thought should have happened years ago. And what that would mean is that you could put money into an account for a diabetic and say, if you're willing to manage your own care, here are the dollars you can do it with. And you could do that for many other chronic diseases. And that would allow you to do what you're talking about doing without ridiculous restrictions on the HSA accounts.
We have 2 minutes left. Does anybody else on the panel have a question? Impressive. You spoke for an hour straight. I don't think you looked at your notes once. You answered a bunch of tough questions, and you provided some really, really good perspective. Thank you so much for joining us, and safe travels back home.
Thank you.